Okay, good morning, everybody. Thank you so much for coming to attend our session today. I'm very honored to be moderating set of panelists here. My name is Salamawat Dasta. I am the program officer for PMA, thank you, Performance Monitoring for Action Ethiopia, PMA Ethiopia at Johns Hopkins University, Bloomberg School. I will introduce each of our speakers. After introductions, we will have an order, and they will go one by one to present up at the podium. Each presenter will have a maximum of 15 minutes. Our timekeepers are there to the back. They will let you know when you have 5 minutes, 3 minutes, no, 3 minutes, 1 minute, and time's up. We will strictly follow that timing so that we have enough time for questions and answers. Okay? Wonderful, wonderful. So our first presenter today is Dr. Mafusa Musumi. She's a public health professional working in South Asia, in the South Asia region. Currently, she's working as a senior technical advisor with the International Planned Parenthood Federation, leading abortion and SRH portfolio across South Asia. Dr. Masumi, please.
Microphone ready, right? Good morning. Thank you everyone for joining this session. And thanks, Ms. Salam, for your kind introduction. So with me, I have actually, I will be talking on the Nepal experience on the task shifting policy for ANMs, auxiliary midwives, who are the mid-level provider. They are allowed to provide medical abortion care across Nepal. So I would like to introduce my colleagues from Nepal, Mr. Pramis Thapa, and Dr. Om Prasad, and Narayani. He's the young champion from the Nepal. So they're really the ground people who leads the intervention, and also they will be sharing their first-hand experiences during our question and answer session. So with that note, so I would like to start with a little bit of background of this, task shifting policy, which really the government of Nepal in 2019, they approved the task shifting policy for auxiliary nurse midwives, the mid-level provider. It was used to be by the doctors and staff nurse initially for the medical abortion. But they approved this task sharing policy, and during the COVID-19 period, they felt a need for medical abortion service for the communities, especially who are hard to reach, marginalized, diverse, who are not able to actually access the services in general. But during COVID, the accessibility of medical abortion, accessibility of abortion care, surgical, and the entire service package was like really in very difficult for them to reach and take the service. So with that backdrop, government of Nepal thought about this task shifting policy, and they approved this policy, which ultimately EPAN, Family Planning Association of Nepal, who is the member association of IPPF, South Asia, under South Asia region. So they are leading the entire task shifting policy, and they introduce a great model, which is a medical abortion care, which is been given by the auxiliary midwives at the very rural areas and also city areas, valleys and marginalized populations. So it really created that environment. If we talk about the intervention model, so it was like as usual intervention model. It was because they had a very positive, flexible policy for abortion in the country. So they approved the first trimester initially, and incrementally they are increasing their flexibility around the abortion care, and they introduced second trimester abortion up to 28 weeks, which is a big, space for providing the abortion care, which tremendously increasing the accessibility, affordability of the abortion care services by different group of people, especially younger girls and marginalized population. So in this MMA model, they trained ANMs, which is the mid-level provider. They provide mainly the primary health care service, comprehensive sexual health services, and also the family planning distribution, as family planning service counseling and distributes the methods. So they were trained on this. There was a 5 days training on the national curriculum. EPAN was part of that developing the curriculum also with the government, and that training was rolled out, and they trained this group of cadre and placed them in the family health center and community clinics. You understand the community clinics are really very much close to the community, and those providers were providing different services, so they included the medical abortion there. And the combi pack availability and stock was given, and there was 6 to 7 months stock they used to have in hand, so that uninterrupted supply can be given and the service can be given with quality. And also there were some community mobilization activities they designed, and it was like linked with their regular community activities, and they added few special focuses based on their need from the community. So I'll be talking on that later on. So this was the model which has been given at the very much community level service center, which is a small setup, but the ANMs are providing the medical abortion service. So ANMs are allowed to provide medical abortion up to 10 weeks. Doctors are also allowed, but now task has been shifted. So now more ANMs are providing actually the medical abortions. So doctors are more providing surgicals and advanced level abortion cases. Up to 28 weeks, they have the flexibility to provide if they have the training and certification. So EPAN introduced this service model in 7 provinces of Nepal, and it was with the 18 family health center and 25 community clinics, so which is a big setup. So the family health centers are the kind of static clinic. When the community clinic provide the services, they provide the backup support and linkages for referrals and other services. So the structure was like that. And 43 ANMs were trained on this, and they are placed in the outreach clinics. And they are also engaged. And there was a monitoring system they established for the data collection and providing some support for the ANMs by the doctors and staff nurse who were more trained and who had the advanced knowledge and skills. So they were providing some periodic visits, and they are providing them support to implement that medical abortion at the community with quality. So now I'll be sharing like little bit of results, which I brought here the key results. I'm not going into very detail, but if you have any question, my colleagues are here and I'm here, so we can discuss parallelly. Maybe because of time, I will be just focusing on the key results. So if you can see this medical abortion services during 2020 and 21, it's really taken up, and it's going up and increasing by time. And so around 6,600 cases were managed in 2020, and then it is again increasing, so around 6,800 and plus cases are, clients took that service. If you see the follow-up is really not happening at the beginning, because you understand that we have started this intervention in 2020 and 21, so there was couple of times of lockdown and pandemic situation, so it was not really easy for the clients who are residing in a very remote place or valleys. If you see the Nepal's geographical situation, so it is very much challenging for them. So about 50% clients did the follow-up on within the 14th day of the medical abortion pill they took. And if you see the post-abortion contraceptives acceptance, it was also not that high as we expected at the beginning, because one cause of follow-up was less. Number second cause was like many of the girls and women, their spouse, their husband lives in the other country. They migrate for the work. So they think that, okay, regular contraceptives is not needed. So they want to actually complete the abortion, and they go for some time not deciding, and they say that, okay, we'll decide, and I have to talk with my husband, and then I come back and take that. So that was the thing. So around 65% coverage was there for post-abortion contraceptive for the abortion clients, medical abortion clients. Now I will be showing like what are the differentials among the medical post-abortion contraceptives. So if you see that oral OCP was the highest popular method they took, and the injectables, and then implants, and IUCD. If you see the overall, trend of IUCD, not in only in Nepal, but other countries like Bangladesh, India, everywhere IUCD acceptance is very low. So we can see the same situation here also, but you see the implant, which is really rising, and it is getting popularized among the communities, and especially for the post-abortion contraceptives, they are moving towards the LARC mainly, which is the main boost is from the around the implants. So we have some good lesson learned. So I picked up some key lesson learned we learned during that journey of 2 years. So A&M, where auxiliary nurse midwives were really found competent and confident to cater the medical abortion services without any major complications. So we had less than 2% complication among this entire the number, so which is very minimum in compared to the service. So, MMA is contextually fitted because it is near to community, and it is provided by the A&Ms who are actually providing their services from the community level, and they do go out to the outreach setup, and they can provide the referral, post-abortion counseling or any kind of support they needed, that also available. Then acceptors are incrementally, the MMA medical abortion is really going up. So I can say that it is it is doubled in 2021. When they started in 2020, the surgical abortion was up, but medical abortion was low. But with this effort, actually, medical abortion now, 70%, around 70% is medical abortion, and only 30% or 35% is surgical abortion. So medical abortion is really taking up and is going, increasing over time. So, and MMA is found popular among young people. That was one learning from our project. So we have seen when we segregated the age, then we saw that 50% of MMA acceptors were from the 15 to 24 age group. And it was about 50%, so it's a huge number. And then obviously we found there was not follow-up 100%. They were reluctant or not able to come to the community clinic or facility for the follow-up, because we have seen and discussed, and in some exit interview also, we found that why they didn't come, because the abortion was totally complete and smooth. So they did not have any complication or anything. So it was very smooth, and they could manage by their own. So they didn't feel to come for the follow-up. And another thing was distance, obviously. Then also found post-abortion contraceptive uptake was little low because we want to get coverage like at least 95% plus coverage for the post-abortion contraceptive, but it was not happening. So that was one learning. But implant was impressive. It is uptaking and increasing over time of the period. So to address this gap from our learning from 2020 and 2021, so in 2022 at the beginning, we actually set with our member association, Family Planning Association in Nepal, and we were engaged from the IPPF South Asia region, and we actually revisited our approaches and also re-strategized some of the elements and approach so that it fits well with the need of the community. And for that, we designed home-based abortion care model, which is introduced to enhance the accessibility and also to ensure the quality of care, especially the follow-up and all those things can be done. So ANMs are now roaming at the community. They're going out to the home if client prefers. Sometimes client do not prefer provider to come their home, so they come to the nearby clinic or some places they prefer. So where our ANMs provided the follow-up and also the post-abortion contraceptives, short method, but for the long-term method, they have to come to the facility nearby and they schedule that appointment and they provide the services. So they are linking them with the services and they can track that client. So another platform we created, that hotline was there from the beginning of COVID for other SRH services. So that they have enhanced the efforts and they strengthen the hotline services so that by phone and by hotline they can reach out to those clients who are lost to follow up. So they were been providing follow up through hotline channels as well. And it was popularized. One concept was the satisfied client. So you have seen in one picture I have shown, so they do the session at the community. So satisfied client who actually went through the same process. So they provided shared some knowledge, experiences, and they also provided some, information or support kind of thing for the other clients. So that was a good model. It was one of the successful. So we need little bit of more time to say that that was an effective approach because we have just started that approach. And also targeted community mobilization activities for young people is designed, and social media boost was there. So text messaging, social media, information giving and updating, and also they can reach out social media also promoting the hotline numbers. So anyone, any young people, they are interested or they have needs, so they can reach out to that through that hotline and they can talk with our counselor or our frontliners who can provide her information and guide her on the different processes if they have any questions. And also we engaged, community leaders, teachers, and religious leaders to reduce stigma. They had the VCAT training, value clarification training for them, and also for the staff at the beginning. Because they were providing the surgical abortion from the beginning. So there was VCAT training which was imparting for the communities and for the service provider as well. And men were engaged and sensitized through different channels. So one was the digital platform was open for male and female, everyone. So everyone was engaged through that, giving some information. But we had the fathers group at the community. So there were some session with the fathers group. They accommodate, they collect, they sit with community leaders or fathers group. So they provide those kind of information and they try to sensitize them. And also because in decision making sometimes men are we have seen that they are playing a critical role. So that's why it was done in that way. So after this, actually, so after this, the task sharing, the program implication was like, it was a good task sharing model which adding significant value to the entire health system to provide broader SRH. And also home-based abortion care is one of the recognized model by the government and the community. And they can strengthen this further to provide the self-care model. And EPAN is the largest organization and they are engaged with the government doing policy advocacy and also providing training support for the government, private sector and the NGO providers for accessing and expanding this medical abortion service in the country. So thank you for your patience hearing. So if there is any question, we have slot so we can take questions later. Thanks.
Thank you so much. Sorry. Thank you so much for that. I think there was a bit of a misunderstanding on time management. That's miscommunication. I apologize. Our next speaker comes from Kenya. Mr. Hambule Mohammed is an epidemiologist with the Ministry of Health, Department of Family Health, Division of Reproductive and Maternal Health, Nairobi, Kenya. Thank you so much, Mr. Mohammed. The floor is yours. And just to note, we will save the question and answers to the end. I will let you know when you have 3 minutes and 1 minute, and your time is up.
Good morning, everyone.
Good morning.
Thank you, Salam, for the introductions. And I would like to recognize the presence of the head of the Division of Reproductive and Maternal Health in Kenya. If you could just wave. Thank you. We also have the Kenyan delegation, the Kenyan team. If you can just wave. PS Kenya. Yes, and I think there was Chepiego. And in Kenya, we say karibuni sana. Most welcome. I would like to take the next few minutes to take you through a strategy to expand access to family planning services in rural Kenya. And here we're talking about a coastal town by the name Kilifi, where we started a project by the name Riziki. Riziki in English, Riziki is a Kiswahili word, which means sustenance in English. Into the content, in terms of background, we aim to connect supply and demand at the community level, and using the community-based approach to offer safe injections, safe family planning methods, including injections and implants. That's the map of Kilifi. It's a rural setup. The prevalence rates are way below the national average. You can see 39 compared to 61. There is also over-reliance on short-acting methods, and the county is considered hard to reach. What drives those low indicators is, of course, what we know: socio-cultural barriers, myths and misconceptions, inadequate availability of family planning services, sometimes stockouts that last for a long time. I've talked about this, I think, in the earlier slide. So Project Riziki aimed to address supply and demand barriers, and spearheaded by the Ministry of Health, together with our partners, Population Services Kenya. We initiated to do a pilot project for task sharing. My previous presenter talked about task shifting. Here we are not shifting, we are sharing. Where there is no nurse, there is a community health extension worker. Remember, these community health extension workers are not routine or traditional service providers for family planning. This is the first time we are bringing them on board, just like we did for community health volunteers back in 2010. So community health extension workers are employees of county governments. They earn salaries. They are slightly different from what we call community health volunteers, where we have to advocate for stimpeds. These are people who are on salaries, and they have been employed by government and deployed to the lowest level facilities, including dispensaries, and they mostly work within a community setup. So just a few figures that show how Kilifi County at that time before the pilot, the figures look like that. Of course, in terms of total fertility rate, they still are the leading. In terms of teenage pregnancies, you can see Kilifi County compared to the other adjacent counties of the coast and the CPR, you know, for all, and modern CPR, MCPR. Still, we have gaps and challenges in that area. Sexual debut, you can see 15 to 19. Still, in Kilifi, we have mothers who are probably 15 or even younger. This is sexual debut, again, disaggregated in terms of age, and the situation is still the same. Fertility trends and intentions, there are those who would want to limit children, those who would want to space, those who would want to have fewer children, 0 to 2, and so on and so forth. Still, this is a slide on fertility trends and intentions. But as you see this, they're spacing, limiting, and need no more children, or they need to get pregnant. But most of them, of course, do nothing about it, meaning unmet need for family planning. Now, in initiating the project, this is the sequence of events. In the first place, we conceptualized. We went into stakeholder engagement, study approvals, baseline assessment, training, both theory and practicals or skills building. The community health volunteers were placed under supervision just before the assessment, and then graduation, finally deployment to their areas of work. Thereafter, we followed up with the routine support supervision, coaching and mentorship of the same trainees, data collection, analysis and synthesis, national and regional dissemination of the findings have been done. And now we are here sharing knowledge and results at the ICFP. This just shows how involving the training has been. 1 week of theory, 2 weeks of classroom skills building, not 2 weeks, 1 more week, placements in high volume facilities, and lastly, they were placed in their community health units. What you see there, CHU, we have community health units that are manned by the same community health extension workers. During the training, they were able to interact with a few methods. They were able to provide proficiently, and before they graduate, we expected a minimum number of 30 clients per trainee. But here we have surpassed the participants' exposure ratio. As you can see, each participant was able to serve 41 clients or so. This is an exposure ratio just during training, before they were deployed. In the skills assessment, in terms of competencies, we were able to test their competencies, and yes, as much as 90% for DMPA IM injection, and for one rod implant, 83%. Now, project intervention, we have increased access to a wider range of quality FP products for women of reproductive age. We also wanted to, of course, drive demand and generate evidence, which we share today. The study objectives was to generate evidence on task sharing. Specific objectives: increase informed demand, increased availability of methods, choice, improve social and policy environment, generate evidence on task sharing for knowledge management. Findings, and here I want to go into how this has happened. This is just a slide to show how many more stakeholders were involved, up to the training institutions, Kenya Medical Training Colleges, the mid-level colleges where community health extension workers were supported. We aimed to train 39, but 3 of them fell on the way, fell out of the system, and we remained with 36 graduates in terms of community health extension workers trained on family planning. I will skip this because this is a narration of what has happened, or how it started from conceptualization to the final end. Now, we found statistically significant increases in implant provision. Remember, this is a county that was largely over-reliant on short-term methods. We wanted to move them to long-term methods. Overall provision per facility per month increased. And we also have found that task sharing is accepted by the community and is scalable. Now, in terms of knowledge on methods, most respondents, of course, knew about injections, which is a mostly preferred method, followed by implants, pills, male condoms, and the rest. Now, what has this project done? Of course, it has supported, together with other interventions, to move the CPR for Kilifi County from 39 baseline to 46. This is a very interesting slide. We have the SCAF for family planning for the country, where we have clustered many of our counties. The first cluster, there are about how many clusters there? 1, 2, 3, 4, 5, 6. 6 clusters. We have huge disparities in terms of CPR, where some regions are way below, while others are way ahead. And Kilifi, as you can see, is somewhere along the second cluster. With the intervention, we found that we were able to move Kilifi from the second cluster into the third cluster in terms of CPR. Of course, you can see the other movements of probably due to other interventions in the other regions. And most particularly, we can quote West Pokot, where we train community health volunteers to offer FP commodities, including injectables, both IM and subcutaneous. Okay. Here we are looking at exemplar counties. Previously, we didn't used to have Kilifi anywhere near exemplar counties. Now, we have Kilifi as the second exemplar county in terms of improvements for CPR. This shows an annual growth rate of each county, and we still have the name Kilifi in that exemplar county growth rate. In Kenya, we have 2 methods that are very popular, injectables and implants. The rest, of course, are also being utilized. In terms of effectiveness, and you may ask safety, we haven't had any, in the period where we were implementing this, there were no safety concerns, both from the community and the healthcare providers. Now, nearby government facilities are the main source of, current FP methods, although we also have private and faith-based facilities. Yes, this still shows the same reason for picking source. We can have cost issues come out strongly. We also have it is nearby, it is accessible, it is available, and the rest. Now, in terms of future intentions for use of FP, yes, these categories,
Sorry,
15 to 19.
Mr. Mohammed, I'm sorry to interrupt you. If you could just get to the conclusion
Okay.
so our panelists can.
Finally,
Thank you.
recommendations. The findings reveal that Kilifi learnings are scalable, advocate for policy change to include choose in delivering of FP services, include training models in the pre-service trainings, mobilize resources for scale-up, and the next steps, of course, we will continue to engage other stakeholders, mobilize resources, and share findings as we do now. Thank you.
Thank you so much, Mr. Mohammed. Sorry to cut you short, but that will leave us plenty of time for question and answer. Our next presenter is Dr. Awal Yimmer. He has about 16 years of experience in managing developmental, reproductive health, family planning projects. Dr. Awal has been responsible for the design and implementation of Packard Foundation-funded RH project activities. Dr. Awal has also worked as a lecturer and researcher in public health universities throughout Ethiopia. He has a PhD in public health studies, MPH in reproductive health, and a bachelor's degree in nursing. Currently, he works for the Ethiopian Public Health Association, EPHA, as a RH project manager. Thank you so much, Dr. Awal. Please.
Good morning,
Morning.
and welcome to this presentation session. And thank you, Ms. Salam, for your kind introduction. On behalf of the authors of this research, actually, two of the authors are here, Mr. Tasfa, and also our executive director of Ethiopian Public Health Association, Dr. Alamayo, is also the co-author of this research. Saying this, representing the authors, I'm going to speak on those research evidences generated to answer this central research question. Is task sharing for the provision of LARC, long-acting reversible contraceptive services by health extension workers in the Ethiopian context, community-based health workers, safe and effective? Take a moment and contextualize in your country this big question of task sharing. Saying this, I'll take you through this presentation outline. I'll give more emphasis on the results section of the presentation. Before getting started, be informed that this evaluative research was conducted in 2017-18. So those reports, EDHS reports, as well as other evidences we used are prior to this time period. As you can see from this chart, pie chart, the modern contraceptive prevalence rate among married Ethiopian women reached 35% in 2006 as compared to 6% in 2000. Despite this remarkable increment in the contraceptive prevalence rate, as you can see, let us see the contribution of IUD. It only accounted about only 2% of the total CPR. Implant about 8% of the total CPR. So this tells us the method mix is unbalanced, predominantly skewed to short-acting methods, especially injectable, which accounted about 23% of the total CPR. The other challenge or problem of the family planning program is unmet need. According to the 2016 EDHS report, about 22% of married women had unmet need for family planning, modern family planning, whether spacing or limiting, with a great disparity between the urban and the rural. In the urban setting, it is about 11%, the unmet need, but it is 2 times more in the rural settings. And there are a lot of contributing factors for this low utilization of long-acting family planning methods, as well as high unmet need for family planning. Let me tell you the main reasons or barriers. The first one is the deep-rooted misconceptions and rumors related to LARC methods. And there are also restrictive family planning operational guidelines, especially for those low-level healthcare cadres, which are not allowed to provide IUCD insertion and removal services. And in some areas, there are preference of the selection of the sex of the provider. Women want, female providers to get IUCD. Recognizing these types of challenges, the Minister of Health proposed to adopt and implement task-sharing approach for the provision of community-based task-sharing approach for providing long-acting family planning methods at community-based health posts staffed by level 4 health extension workers. These level 4 health extension workers are educationally equivalent to those auxiliary midwives or diploma nurses who are government employees. As per the 2012 WHO task sharing and shifting guideline, strongly recommend rigorous evaluation before putting such type of practice into action, before starting to the implementation. In line with this, the Minister of Health piloted this pilot program at small scale at 66 health posts in 2016 in 4 major regions of Ethiopia. After it has gone for about 10 to 12 months, the ministry had given the assignment to Ethiopian Public Health Association to evaluate this pilot program. So the purpose of this evaluation research was to evaluate its implementation status, its safety concerns, effectiveness, with ultimate purpose of generating evidence for decision and policy for policymakers. Coming to the methodology part, basically the research had three basic questions. The first one is, to what extent health posts are ready enough and conducive for such type of purposes? So for this, we have audited 50 accessible health posts. And the second important question is, to what extent those trained health extension workers are competent enough, knowledgeable enough? For this research question, we have assessed their knowledge from 51 level 4 health extension workers, and we have checked their skill competency by using senior midwives who have TOT. And the most important third question was, what are the immediate and intermediate outcomes from the user's side and its implementation status? For this, we have surveyed 689 IUD or implant users using systematic random sampling by going to their home. Let us move to the most important section, the results section. As I have mentioned earlier, the first objective was readiness. So in terms of readiness, the main gap is here. About less than 1/3 of this health posts had water, pipe water, and electricity. Majority of them didn't have such type of infrastructure, which are essential for the provision of quality long-acting family planning service, mainly IUCD. And there is also 32% of these surveyed health facilities had JADL, and 52% of the surveyed health facilities had at least 3 durable supplies, which are important for infection prevention. When we see the second objective or research question, about 59% of those level 4 health extension workers had good level of knowledge on LARC in general. And 51% of them correctly mentioned the side effects and the complications of implants and IUD. This chart highlights the evaluated skill competency of those level 4 health extension workers. And I'll focus on the gap. About 35% of these level 4 health extension workers had fair competency in terms of providing client-centered family planning counseling. And in case of JADL insertion, about 8% of these health extension workers have, incompetent, and 16.4% of them were fair competency. In case of IUD insertion, about 16% of them were found to be incompetent, and about 33% of them were found to be fairly competent in inserting IUCD. So what does it tell for us? It implies the need to focus on family planning, counseling, as well as IUCD insertion. Coming to the last but important objective or question of this evaluation research, almost more 2/3 of the health posts had initiated these additional service provisions, like comprehensive LARC service provision, that means both insertion and removal services, and 68% of them had, started insertion of IUCD, and about 66% of them had also initiated or started a removal service for implants. When we see those number of clients who have surveyed, got large service from these piloted health services, about 3,882 women had received implants, and 712 women had got IUCD insertion, and 356 women had got implant removal services. This is the most important results part of this evaluation about the immediate and intermediate outcomes of the program from the user side. About 12% of those surveyed women reported that they have faced undesirable effects, maybe minor side effects or serious complications. Unfortunately, only 2 women had reported failure rate, got pregnant, and 1 woman reported IUCD expulsion. And the prevalence of removal before the due date was 5.4%. So what does these findings tell us? The overall, as a conclusion, the overall readiness level of health posts were suboptimal, particularly the infrastructure and input elements of the readiness of the health posts were very, very below the standard to provide quality family planning services. And less attention was given to the quality of care during the design and implementation phase of this pilot program. And other important issue is the reported poor outcomes. That means the failure rate as well as the early removal rate, the IUCD expulsion rate are comparable with other research evidences, even those clients served by mid-level healthcare professionals like midwives and nurses. Lastly, a general conclusion, provision of long-acting reversible contraceptive method by level 4 health extension workers at the community level can be an effective approach if and only if those main requirements and standards are in place and fulfilled, and guided by strong leadership working at the various levels of the healthcare system. And also it should be supported by the family planning operational guidelines and policy directions. As a recommendation, the Minister of Health should give emphasis on the endorsement of a national implementation guideline on task sharing of this approach at the lower level. Those zonal and district level health offices should give more emphasis, more focus on careful selection of the target health posts which have good infrastructure, and they have to strengthen their catchment-based follow-up and monitoring after giving training. And for the scholars or researchers, we strongly recommend to conduct a further study with robust comparative design like randomized control trial or quasi-experimental design before the scale up of the program. Finally, I would like to, our EPHA would like to acknowledge the Minister of Health for the leadership role as well as provide the necessary information. And we also extend our appreciation to the research team, especially our management PHA management, as well as research participants, and also David and Lewis Packard Foundation for the financial support. Let me say one thing: if we collaborate and work together, we can advance the rights, the SRH rights and health of underserved women and girls. Thank you very much for your attention.
Okay, thank you so much, Dr. Awal, for the insightful presentation on your experiences and challenges. Our last presenter is Dr. Toyin Okomolafe. She is currently a research, monitoring, and evaluation advisor with Population Council in Nigeria. She is working on a project focused on improving access to contraceptives by involving the private sector in family planning service delivery in 11 states in Nigeria. Dr. Toyin, the floor is yours.
Good morning, everyone. My name is Sonia Komolafe. I work with Population Council on the Integrative Project in Nigeria. I'm presenting on behalf of co-authors and partners on the project, some of who are here with me. We have pharmacist Emeka Okafo and pharmacist Olalere. So, as part of a task-shifting, task-sharing project in Nigeria, we conduct an assessment of the family planning knowledge retention of community pharmacists and patent proprietary medicine vendors. These are also known as drug shops in 2 states in Nigeria. Community pharmacists and PPMVs are important to increasing access to high-quality family planning services in Nigeria. For example, 22% of modern contraceptive users actually access the method from PPMVs, and 12% of modern contraceptive users access their method from community pharmacies. So they are key sources of modern contraceptives, though they lack the knowledge and the skill to provide the services. So integrative projects seek to improve access to family planning services by building the capacity of these community pharmacists and PPMVs in family planning counseling, injectable and implant administration. For this study, we aim to answer the following questions. What proportion of CPs and PPMVs retain family planning knowledge over time? And what role do job aids play in supporting knowledge retention over time? A bit more about Integrative Project. It was funded by Bill and Melinda Gates Foundation and MSD for Mothers. As part of the project, we pilot what is called a 3-tiered accreditation system. PPMVs, like I mentioned earlier, also known as drug shops, were categorized into 3 categories based on their health qualification, and this actually determined the type of training that they receive and the services that they provide. We have the Tier 3 PPMV. These are PPMVs that have background as pharmacy technician. They've been to a school of health tech. We have the Tier 2 PPMV. These are health qualified PPMVs. They are previously either nurses or currently nurses, community health extension workers, community health officers. And lastly, we have the PPMVs. This one, Tier 1 PPMVs. This group actually lack health qualifications or previous training. Mostly they are secondary school, persons with secondary school education, and some that have a BSc actually lack health background. And outside this category, we have the community pharmacists, which were also included in the study. We use a quasi-experimental design without a comparison group, and these providers were given self-administered questionnaires to assess their knowledge of family planning counseling, injectable and implant contraceptive services. They were interviewed at 3 time points before the training, immediately after the training, and 9 months after the training. Data collection was between the months of January and December 2019 in Kaduna and Lagos State, Nigeria. To assess their knowledge retention capacity, we actually we use 3 outcome variables: the general family planning knowledge retention. This was measured using 11 items: injectable knowledge retention and implant knowledge retention 9 months after the training. For the mean score of the knowledge retained for each of the category was calculated. For example, for the general family planning retention knowledge, the main score was 5.7. So providers that scored 6 or more are deemed to have a high knowledge retention, while those below 6 have a lower knowledge retention. For injectable, the mean score was 7.9. So providers that scored for 8 items and above have a high knowledge. And for implant, the average score was 2.7. So providers that have 3 are considered to have a high knowledge of implant contraceptive. The independent variables that we examined, the key independent variables were actually the job aids that were given to the providers during the training. The job aids were categorized into 3 groups for their similarities. We have the category 1, which includes the balanced counseling strategy plus counseling cards. We have the algorithm and the family planning flip charts. Then for the category 2, we have the family planning method brochures. And category 3, we have the MEC wheel. Then additional coverages were the cadre of the providers, if they're tier 1, 2, or 3, and CP, and if they have previous health facility experience. Also, for providers that are providing injectable and implants, additional variable was added, which is have they provided a service 30 days prior to the survey. So we developed 3 models to assess the association of the receipt of the job aids on family planning knowledge retention. And these were adjusted for providers' characteristics, which are gender, age, the tier, state, previous health facility experience. So these are the background characteristics of the community pharmacist, tier 2 and tier 3 PPMVs, and tier 1 PPMVs. The tier 2 and tier 3 PPMVs were actually merged together because we have fewer tier 3 PPMVs enrolled on the study. So looking at the table, we realized that females were more enrolled than across the different groups compared to the male. Study was conducted in 2 states, which is Kaduna and Lagos. In Lagos, community pharmacists were more, that's about 73%, while in Kaduna, we have more of the tier 2, tier 3 PPMV, which is 93%. The green bars showed the proportion that answer correctly at post-test, while the blue bars showed those that retained the knowledge at 9 months. Some providers have high knowledge. There is high knowledge of some items at post-test, and most providers were able to retain this knowledge at 9 months, while for some, the knowledge was low at post-test, and those that retain it at 9 months were equally lower. For example, providers that know the lactational amenorrhea method as a modern method, 27% answered correctly at post-test. And out of this 27%, only 18.5% were able to retain the knowledge at 9 months later. For the knowledge retention when it comes to injectables, so for knowledge when it comes to injectables at 9 months, this also showed a high knowledge among providers for most of the items at post-test. And before I go on, these questions for injectables and implants were actually focused on community pharmacists, Tier 2 PPMV and Tier 3 PPMVs, which were the groups that were trained to provide these services. So here we exclude the Tier 1, which were not trained to provide these services. So for example, providers that know that Unijet is used to administer Sana Press at post-test was 88.5%, and out of this 88.5%, 95.1% were able to retain the knowledge at 9 months later. So for the sample size, like I mentioned earlier, it's also lower for implant compared to the general family planning knowledge. So here also, for at least 4 items, there was high knowledge at post-test, and providers that retained this knowledge at 9 months later were equally high. However, for providers that know that after Jadel insertion, providers that are aware that after Jadel insertion, you are not expected to drop your instrument in a soapy water, wash, or sterilize in this manner, were actually 22% at post-test, and fewer were able to retain this knowledge 9 months later, about just 8%. So for our multivariate analysis, providers that received a balance counseling card or a balance counseling algorithm or family planning flip charts, they have a higher likelihood of retaining the general family planning knowledge. And providers that receive the family planning brochures are likely to retain knowledge for implants. While providers that were given a Merck wheel, in this case, Tier 2 and CPs, they are likely to retain, at least twice likely to retain knowledge for injectable, and also likely to retain knowledge for implants. So knowledge of general family planning, injectable, and implants was better retained for some question over others. Receiving job aids appeared to support knowledge retention. Balance counseling materials supported general family planning knowledge retention. Family planning method brochure supported implant knowledge retention. And the Merck wheel supported injectable and implant knowledge retention. In conclusion, CPs and PPMVs can retain information learned in a training 9 months later. Refresher training are necessary to actually retrace messages that were not retained. Knowledge retention can be supported through job aids, suggesting that they can offer when they will be able to offer continued information that is accurate and quality services when they have a job aid. Targeted training help community pharmacists and PPMVs retain knowledge, and when they were exposed to during the training interventions. Thank you for listening.
Thank you so much, Dr. Toyin. Thank you to all of our esteemed panelists. We'll now open the floor to questions and answers. I know we have delegations representing everybody here, so it should be a very rich discussion. I will ask that you keep your questions concise so that those who want to ask questions have the opportunity to ask. We will take about 3 to 5 questions at a time so that we can have good discussion. Thank you.
Thank you. My name is Tasfa from Ethiopia. I would like to thank all presenters for your presentation and clarification. My question goes to the Kenya friend. I want to know your opinion on the support you are giving now and the sustainability after your project phases out, because you will not be there forever. So what's your opinion in this case? Thank you.
Thank you.
First of all, thank you all of the presenters. And My question goes to the Ethiopia colleague. As you have mentioned about in your slides about the, like uptake of LARC method, ICD and implant was low in Ethiopia, and you have shown in your presentation. And what the cause is the, the challenge was there is the misconception among the community, which was the one of the cause you mentioned. And my question is to overcome these challenges, what strategy you have adopted in the to increase the like a LARC method, ICD method in your country? Thank you.
Okay. Any other questions?
Thank you very much. My question goes to the last presenter. Why do you think the average level of knowledge for one of this, I think injectable is about 2 point something?
Implants.
Implants, yeah. Thank you.
Okay. Any further questions at this time? Okay. Mr. Mohammed, first.
Yes, thank you very much for the question. Regarding my opinion on sustainability of this project, the utilization of community health extension workers arose from the need to improve access within the rural setup in hard-to-reach areas. Previously, we were using community health volunteers. Volunteer meaning they were not on any payment. They are not obliged to provide services, only on voluntary basis. This project is slightly different because it takes care of issues to do with income. Community health extension workers are employed staff of government. They earn monthly salaries. They wake up every morning to go to work. And we only utilized them further. Apart from their community health work that they do, they help us increase access to family planning by training them and giving them the skills required and the equipment and the commodities. So in that sense, the expectation, the monetary expectation is sorted. Probably we should be thinking about how do we maintain our stocks so that they don't get stockouts along the way. Because when you create demand and your supply side is not sorted, you will obviously go into problems. At the moment, we have moderately very reliable stock levels. We are not worried. We are working towards making our supply chain better as we scale up this. Thank you.
Okay, thank you. Dr. Awal?
Thank you for the questions. I will come to the question. After we have conducted this evaluative research, the Minister of Health has made a lot of things, strategic interventions. For example, the Minister of Health, based on our research findings, developed and endorsed an implementation guideline on task sharing for the provision of long-acting family planning methods at the community level by using these health extension workers. That implementation guideline consists of very comprehensive strategic intervention. One of the intervention is promotion and demand creation. In those promotion-related issues, one of the big challenge, as you mentioned, is, this misconception and rumors, which is deep-rooted in the community. For example, women think that if we insert implant, we couldn't perform those hard and very loaded activities. And especially those Muslim women also perceived that if we inserted IUCD foreign items, we may not get the heaven if we got die. So we have at least designed 3 strategies in that implementation guideline. The first one is community conversation at the local level, including religious leaders. And there is also a women developmental army and health extension workers. Through the facilitation of these health extension workers, at the community level, we have, or the Minister of Health has been doing a lot of activities in order to address and rectify such type of misconceptions in rumors. EPHA, with financial support from Packard Foundation, had implemented this project as a lesson for the Minister of Health, and also using these social medias, local social medias, local radios, local FMs, we have also educated the community at the rural about this issue. Thank you very much.
Thank you. Dr. Toyin?
Okay, thank you for the question. The reason why we have a low average in terms of knowledge of implants, it may be due to that this particular method was newly introduced to the providers, and it's not something they previously provided. To provide more context, previously before this intervention, PPMVs, Tier 2 PPMVs, Tier 3, and community pharmacists, they were not allowed to provide invasive methods like injectable and implants. So for us to train them, we got a waiver from the government and trained them to provide these services. The knowledge for injectable was high because even though they are not allowed to provide these services, some of them were actually doing it illegally, doing it as something along the side. But when they now receive this training, some of them are already familiar with injectable. But when it comes to implants, it's a totally new procedure that they need to learn. So this is, I believe this is one of the reasons why we have a low average. Thank you.
No problem. Any other questions from the floor? Okay. All right. With that, I'd like to thank our panelists for sharing their research findings with us, their challenges, their experiences, their successes. And to everybody who joined this morning, this afternoon, thank you for attending. I hope you all take time to attend the final closing ceremony, and safe journeys for those of us who are not from Pattaya. Thank you.
Thank you.